families in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome to Dr. Gore Show. As we all get older, and a lot of our relatives, our friends, our parents are going through hip and knee issues, and we hear about knee replacement, hip replacement. So it's a very common topic close to our families and our friends. And to enlighten us on this topic, we have Dr. Tejwani from NYU. Welcome to Dr. Gore Show.
Thank you for having me.
Dr. Tejwani started his career at University of Bombay, where he did his training in orthopedics. Then he went on to London, where he did FRCS. Then he moved on to United States, and he went to Seattle to do his fellowship. And for the last 15 years, he's been at NYU in the New York City. So what's hip and knee replacement? Like, how many people in their late 50s and 60s undergo this kind of surgeries?
So this has become an extremely common surgery in not only in the United States but in the whole world. It started about 40 to 50 years ago in England, where they started with hip replacements, and then since then, I would say to you that without any doubt, this has been the most successful operation in orthopedic surgery.
Right. So it started with the hip, and is the knee more common than the hip?
Correct. So even though it started with the hip, and hips have been very successful, so have been the knee replacements.
Right.
And people seem to have more knee problems than hips. So in this country, for example, about 250 to 300,000 knee replacements are done every year.
Wow. So that's a staggering number of surgeries that are done.
Correct.
For benign or non-emergent basis. So tell me, when do the people just come up to you that I have knee pains? And so what are the criteria that they have to meet before they undergo surgeries? Like, do they have to go through some testing? Do you tell them to do some physical therapy? What's the process that leads up to knee replacement?
So classically, as you said, it's an older patient. As we all get in our 50s and 60s, the classic is your knees hurt. The wear and tear. Your knees start hurting, especially if you try to go up and down stairs, or if you are trying to play with your children or grandchildren and you try to get up from a squatting position and knees are very painful.
Right.
These might be indications that you are developing arthritis.
Right.
The first step is usually an X-ray for the diagnosis of arthritis, because on the X-ray you will start seeing changes in the knee, where the normal natural space in the knee joint starts getting smaller, and the cushioning effect is going down, and then people start developing arthritis. Initially, the treatment we try without surgery. So classically that involves having physical therapy, an exercise program. Weight loss is very helpful. So if you are overweight, for every pound of weight you lose, you are going to decrease about 3 to 5 pounds of pressure on each knee.
Correct.
So even if you lose 5 pounds, it doesn't sound like a lot, but it will have a significant effect on your knee pain. So that's the start off. We also would recommend taking some anti-inflammatory medicine. So whether you're taking Advil or Motrin or Tylenol, as it might help you. Once that's done, usually these things help. If these things don't help, or the pain starts getting worse, the next step classically would be getting injections in your knee, and these may range from simple cortisone injection, cortisone shots, which gives you temporary pain relief. Or now we have these new fluids that we inject, lubricants that we inject in the knee, and that's usually a course of injections between 3 and 5.
So those are like a temporary measures, correct? Like those fluid injections or even steroids to get down the inflammation, it's a very short-lived, right? They have to go back a few weeks to get it injected again. So this is sometimes when somebody can't do a major surgery, or you want to try it out, how much is the pain relief. Those are the patients you will try this treatment.
That's correct. That's correct. So if the patient's the arthritis is not bad enough to merit a knee replacement, or somebody who is hesitant about surgery and they would like to try these measures first. And you're right, they are temporary. And in some cases, it may last a few weeks or a few months.
Right. So it's nice to know that you could start with some injections and therapy and see if improvement. maybe few people might feel some benefit and can postpone this for. Now, do they have to go, apart from the X-ray, do they have to do like a MRI or CAT scan of their knee before they undergo any replacement to see, the other structures around it? How does that work?
So in the early stages of knee arthritis or knee pain, an MRI scan might be useful because it will be able to tell you if the pain is coming from just the arthritis, or you might have damage to the meniscus, which is the cartilage inside your knee, which may benefit from some minor surgery like arthroscopic surgery. But usually once the arthritis is advanced, it is very obvious on the x-rays, and an MRI is not necessarily very helpful.
Okay. So once you've decided that this person is a candidate for a knee surgery or a knee replacement, are there different kinds, a partial or a total? Like, how do you make a decision which one is right for which patient?
Correct. So the commonest knee replacement done is a total knee replacement.
That's what we have here?
That's what we have here. So if I can show you these parts of the knee, what we have here is the thigh bone or the femur, and then here's the leg bone, which goes into your ankle. And right in between you can see there's two parts. I'm just going to stretch it out. And essentially the way it is you have a metal part on your femur or your thigh, and then you have a metal plate with a plastic in between the tibia or the lower part, and you can see the way it meets together, and then this is how your knee bends. And the idea is that you take away all the damaged or arthritic bone and replace it with this artificial knee joint. There's also a plastic cap, which is your kneecap, which can also be replaced. So this is your classic complete or a total knee replacement. Now you have the option, depending upon the kind of arthritis you have, of having a partial knee replacement, what is known as a unicondylar knee, which means, as the name implies, it's half. So if you look at the knee here, it's only half of it, and classically it's done on the inside of the knee, which is the most common part that gets arthritis.
Because of the pressure.
Because of the pressure and the posture of our leg. Now those are obviously, again, surgeries that work for a while and may be very well suited for patients who have arthritis only on part of their joint, and it might be helpful. Eventually that might need to be converted to a full knee replacement, but that could be done as well.
So it's like more like a carpentry, right? You're taking out a part of the bone, you're cutting the part out, and then you putting this metal. Now, how complicated is this procedure? Is the patient bleed a lot? Like, how do you counsel a person undergoing this surgery? What are the risks of this surgery, the benefits, and what to expect? How do you counsel these people?
So the way I explain this to patients is that once you have to be sure that your knee is bothering you enough that you want to undertake surgery. We consider this to be major surgery because the complications can be significant, though the benefits usually are better or outweigh the risk of complications.
And that's because of the major blood vessels which are in that area that run through.
We're concerned about damage to the tissues in the neighborhood.
The muscles.
The muscles. So one of the commonest complications would be stiffness of the knee after the surgery. So we have to get you aggressive physical therapy after the surgery. So a patient who undertakes the surgery has to be prepared to be pushing through the initial post-operative pain.
And work through the pain, because it's going to be painful, but they really have to work their knees to be successful mobility-wise, correct?
Absolutely, and that's really the success of the surgery, is taking away the pain and giving you mobility. And so if you do it in the initial parts with physical therapy, then it's a remarkably successful surgery. Post-operative, usually the patients in and out of the hospital usually within 3 days or 4 days, and they're able to go home and start therapy from home, and they're able to walk on this pretty much right after the operation once their pain is under control. Usually by, I would say, between 8 to 12 weeks, the initial recovery is complete, and after that, most patients are allowed to do almost all activities that they were able to do before the surgery or before their arthritis started.
Wow. So we're going to take a quick break, and we'll be right back to talk about knee and hip replacement. Be right back.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back to Dr. Gore's show. So today we've been talking about mainly knee and hip replacement. And to talk about this important topic, we have Dr. Tejwani, who practices in NYU. His information is on the screen, and you guys can go and visit him. So far we've talked about knee replacement, how patients come to you with pain, and a standard injection, physical therapy hasn't helped them as much. And they decided to undergo knee surgery. Hopefully the replacement went fine, and now they have to do physical therapy. And as we discussed, the physical therapy is to get the mobility going. That way you have the best outcome of the surgery. Now, most of the time patients would ask you, is it okay to go through the airport scanners? Is this something that requires to be announced when they are going through malls? So what's the answer to that question?
So that's actually a very common question, as you say, because this will set off the metal detector.
Right.
So when you go through the airport security, my recommendation is to warn the TSA officers that you have a knee replacement.
Do you give those people a card saying that they have this?
So if the patient requests that, yes, we will give a card, though the TSA will probably still do an individual check.
Sure.
But absolutely, you should inform the TSA agent that you have a hip or a knee replacement, and that is expected to set the alarm off.
Correct. And now they've gone through the therapy. What should they expect to do? Most Indians like to sit down. They like to cross their knees. Can they do that? Is there any restriction on any contact sports, that they can do or not? So what's your long-term advice to keep this as much in a good health, like your own knee?
Correct. So now the knee replacement, the way you think about it is it's a plastic that's going to wear out over time.
Right.
So the actual lifespan of a knee replacement can range from 10 to 20 years, depending upon, as you said, the activity level. So the recommendation usually is that once you have a knee replacement, you should try and avoid impact exercises. So running would be a great example. Playing tennis would be another example. Usually we don't recommend doing these activities once you have a joint replacement. With hip replacements, some people are allowed to play doubles tennis, but not singles because it's just more aggressive and more active. There's more impact. With knee replacements, regarding your question you asked about squatting on the floor or bending your knee, there is really no restriction. In fact, in demand from the Indian population, they have now what are known as high flexion knees.
Right.
So normally with the knee replacement, people are able to bend their knees just so they can sit in a chair.
Right.
But with the Asian population wanting to bend their knee and sit on the ground,
Right.
they have the high flexion knees that allow you to bend your knee a lot more.
Wow.
Without causing damage to it.
Right.
So there is no restriction from the point of view of sitting.
Right.
Of course, you have to get there, which is what the physical therapy is going to do.
Now, as you mentioned, in 10 to 20 years down the road, how will they know that their replacement needs to be replaced again, or a new device has to be put? The pain comes back, or the mobility gets affected, because there's no sensation now. So how would they know when it's time?
Correct. So usually it is pain. Pain is a classic signal. And so the way it goes is the first 5 or 10 years, most people are doing very well. They usually don't even go to their doctor because they're feeling so good.
Right.
And then after 10, 15, or 20 years, as the time might be, once they start getting pain in the knee, they would go visit their doctor again and say, well, I'm beginning to get pain that I did not have before.
Right.
And then further x-rays will be needed to see if there is any evidence of loosening of the implant or a wearing out of the implant where the gap becomes less.
Right.
And if that happens, then they might need a second operation.
And is the second time going in more difficult or easier? How does that work out?
It's usually a little more difficult because it's a little more
Scarring.
complex. It is more scarring. You have to take out what's already in there and replace with a new thing.
Right.
The good news is as years pass by, the technology improves, our surgical skills are getting better.
Correct.
So 20 years ago, if somebody had said I need to do a second operation, most people would be hesitant to do it.
Correct.
Now, people are living longer.
Sure.
Surgeons have got more experience, and we are able to do a second, maybe even a third operation.
Wow. So it's looking, the future is looking better and better. I think the technology is improving, and hopefully by the time I'll need it, I think we'll have a much better equipment. So now let's talk about hip replacement, right? Because hip pain, as you said, it started for the hip pain. Now, the knee I can understand, the wear and tear, the standing, arthritis, kind of knee is a common thing. Is there any risk factors for the hip which make somebody get more pain, and at what point would they require a replacement?
So in the hip joint, you're absolutely right. The wear and tear is there. They do get the what is known as the osteoarthritis, which is arthritis related to age, which is still the commonest reason why people get arthritis.
Correct.
But in the hip, there, as you pointed out, there are a lot of other reasons.
Right.
So you may be born with a hip that's not normal,
Okay.
which is again a remarkably high percentage of people who have a hip that's not perfectly normal.
Right.
So if you look at the hip joint, if I can show you, I know there's a hip replacement already here. The hip is essentially a ball and socket joint.
Right.
So this is kind of the socket, and then there is a ball that fits into the hip like so. And so what this does is it allows for smooth motion.
Okay.
But over time, if this is not a perfect sphere or a circle, it might wear out eccentrically and cause
Right.
arthritis to develop. The other reasons may be people who grow up with, let's say, asthma, and they've been taking steroid inhalers,
Right.
and that causes the blood supply to the hip to be affected.
Right.
And causing them arthritis. And these are younger patients who get arthritis.
Correct.
So there's a multiple factors that can cause the arthritis. Once you get the arthritis, it usually develops and gets worse over time.
Right.
And the patients will classically come complaining of pain in their groin,
Right.
or it's very rarely on the side of the hip. It's classically in the groin.
Okay.
They may or may not develop a limp because they get pain.
Right.
The other thing that you will commonly hear is, well, the weather is getting cold or damp and I can
Correct.
feel it in my joints. And that's actually true.
Right.
There are changes, the barometric pressure changes, and that reflects itself in joint pain.
Right.
So the older we get, the more we
More
seem to
chances.
recognize when the weather is going to change.
Right.
And once you have that, again, we do x-rays, MRIs, as you said, in early cases
Right.
to show if the blood supply has changed. Well, it allows us to predict, okay, well, you're getting arthritis.
Right.
What
Right.
treatment can we do?
Right.
Now, unlike the knee, which is easily accessible for injections,
I was just thinking that you read my mind. I'm like, you can't try that, or it's technically very difficult because it's such a complex area.
correct, it's a very deep joint.
Right.
So to do an injection in the hip, usually you require x-rays and
Right.
you need to go to a specialized setting. So while injections in the hip are done, they're extremely rare because
Correct.
it's much more difficult
And it's not
invasive.
even permanent solution to the pain. So it's a very temporary relief with a higher risk, correct?
Absolutely, absolutely.
So the injections are not as favorable for hip compared to the knee because it's very accessible. So you found somebody, who is a candidate for, say, hip replacement. The question that comes in my mind as an OBGYN is osteoporosis and osteopenia. And they do have some, arthritis associated with that. Now that having the bone density issue, does that impact what kind of replacement you'll do? Because the bone is so fragile, even the replacement might not work. Or do you build their bones up before doing surgery? How does that work then?
So that's a good question. And so typically when we do a hip replacement, it's, let's say, in somebody who's in their 60s or 70s, and their bone quality is still good.
Right.
If that's the case, then we would do, and here I'm just going to show you what we have here. So what you would do is you would do a hip replacement using something like this.
Okay.
And if you look at this hip replacement, this is what's going to go in your hip. And if you look at this, this is kind of what it's going to sit like
Wow.
inside your bone. And the part that sits inside the bone is designed such that bone will actually grow into it and hold on to it.
Right.
And this is what allows the person to have an artificial hip.
Right.
Now, if you are an older individual where your bone is not very good quality, and we are concerned that this may not grow back in,
Right.
then there is something called bone cement.
Okay.
It's a special kind of fluid that becomes really hard and acts like a glue between the bone and the prosthesis or the hip replacement, so it gets a good fit right away.
Right.
And so what we are doing is we are replacing the hip socket, and if you see it here, this is the hip socket that's been replaced. And then here is the hip right there. If I separate that out, that's the hip, the ball of the hip.
Right.
And there is a hip socket, and then the two of them will meet like so to give you the smooth motion that you need when you walk.
Wow.
Now, with a hip replacement, the one thing that's different from a knee replacement is that depending upon your surgeon's technique,
Right.
they might ask you to restrict yourself
Okay.
in doing certain activities.
Because this can dislocate.
Correct. So the fear is that, as you can see here, that it can pop right out and
Correct.
dislocate.
Right.
And so to avoid that from happening, some surgeons might say to you that, well, you are not allowed to cross your legs. You're not allowed to squat on the floor.
Wow.
You can't get into a bathtub because you have to bend your
Bend
hips
down, right.
a lot. But with newer techniques now that we have, So we have what is known as the anterior hip replacement, where we go from a different direction,
Right.
and we don't injure the muscles while we go in. As we talked about earlier, the
Right.
hip is a very deep joint.
Right.
So if you don't damage the muscles going in, you don't damage them coming out, then you don't have to worry about the hip dislocations to the same degree.
Okay.
So originally patients used to, this procedure is described with what is known as the posterior approach,
Okay.
where you went from the back,
Back
of
of
the
the
hip.
patient. Okay.
And they had a dislocation. Again, it's not very high. It's only about 2%,
Right.
but it is still there.
Okay.
But with the anterior or the what is known as the anterolateral hip replacements, the risk of dislocation is less than 1%.
Because you're preserving the anatomy with the muscles and the ligaments to help support the joint, correct?
Correct. And that's the idea. With the native tissue protects the hip.
Right. So it doesn't let the replacement slip out, and
Correct.
it kind of keeps it in place like a regular joint.
Correct. And then allows people to be able to be more active. So you can sit in any chairs you like. You can get, as we said, you don't have to worry about bending your hip or knee or crossing your legs. All that is usually allowed, as I normally do with my patients, pretty much right after surgery.
Right. So it sounds like a major joint issue, but the way you simplified it, I think it's so easy to understand that you're kind of taking out the damaged part of the knee or the hip and replacing it with a newer metallic and plastic things to make it less impact and less rubbing of those bones. And the most important part about this surgery is to have the right surgeon to do it, find the right time to do it, and also post-operatively to make sure that whatever the surgeon says, the physical therapy, the activity, and to do less of an impact, to keep and preserve this joint as long as you can, maybe 15 years, maybe 20 years, and keep the weight down, keep the activity going, and I think we can get a lot out of the replacement. So can you talk about common sports injury?
So the commonest sports injury that we all have had is an ankle sprain.
Right.
So we're walking down the street, running, as you mentioned, with kids, or even as young adults,
Right.
or as we all play sports. So the commonest injury is you turn your ankle, you roll your ankle over, and you feel this sharp pain on the outside of your ankle.
Right.
And what that is an ankle sprain. Now, there are types of ankle sprains. Essentially, what you're doing is you're injuring the ligament of your
Correct.
ankle, the ligament that lies on the outside, and it can be a minor sprain, which is what is a type 1 sprain. Usually that resolves or heals itself in a few days, and that's the
Just
one.
rest is all you need
Usually,
to do.
the
Right.
classic is rest, ice, elevation, and compression
Okay.
every time. So if you do that, usually type 1 injuries will be better in a few days, and you're back to doing what you were doing.
Right.
Now, type 2 or type 3 injuries are more serious,
Right.
and they can range from incomplete to a complete tear of the ligament. Those usually will require a lot more rest,
Okay.
almost 6 weeks before the healing is complete and people are able to resume sports activities.
Right. So how do you know that this sprain is okay? Just not to see a physician, just rest. Not that we recommend it, but sometimes you put ice pack and it's fine and you forget. But if it's swollen, if there is more pain, it doesn't disappear in how many days? Like, what's the criteria? Then they should see a specialist.
So usually by resting and elevation and icing, usually if it gets better within a few days, which might be 3 to 5 or maybe 7 days,
Right.
then that's okay.
Right.
If you notice a lot of bruising there,
Okay.
and you realize that the swelling is getting worse,
Correct.
or as you try to walk on it, it's very hard to walk on it, or if you're not able to put weight on it,
Correct.
then you must go to the emergency room or go to your doctor, get an x-ray or examination to make sure that, one, you don't have a fracture there,
Correct.
or two, your injury is not severe enough to merit a specialist to see you.
Right. And once they came with a tear on the ligament, or they came with, how do you proceed about, do you put them on a cast? How does that work compared to fractures that we all know? You reduce it and put it in a, cast, and it has to heal, and then you take it. For sprains, how does that work then?
So for sprains, classically for an ankle, as you were talking about, we would give them a brace for an ankle, commonly an air cast,
Okay.
which is like a stirrup that goes on either side of your ankle to give it the support you need
Right.
while you're still able to walk on it. And usually once you do that, it allows the ankle to rest, be
Okay.
stabilized, and allow the healing to progress. Sometimes on a clinical examination, or if the patient presents at 2 or 3 weeks
Right.
and is not improving or seems to be getting worse, an MRI scan might be helpful
Okay.
to show you the extent of damage to the ligament.
Right. And if there's extensive damage to the ligament, sometimes they might even need a surgical intervention to fix those ligaments?
That's correct. Correct. Usually it is delayed by a few weeks to allow the healing, natural healing to progress. And in my practice, usually between 6 and 8 weeks of physical therapy, rest, and strengthening resolves, I would say 85 to 90% of the cases.
Right.
The other ones are the ones that will probably get an MRI scan and might need more intensive physical therapy, and sometimes we might need surgery to repair those ligaments.
Correct. So after they've taken rest and stuff, do you decide when to take it out, or you see how they are able to walk? Like, what makes your decision to take out the restrictions from this patient?
So it's usually how the patient is progressing, how much they're able to do, what activity they can tolerate, how much they're able to walk.
Right.
And most people will tell you, well, I got up in the middle of the night to go and I forgot to put my brace on and it wasn't as bad as I thought.
Right.
Or when I wake up in the morning at home, I don't wear my brace,
Correct.
but I wear it when I go to the office or school or
When you're doing activities.
you're doing activity. And that's a good sign.
Okay, that it's healing and hopefully
Correct.
it will be fine.
Correct. And usually we will see the patients back at 6 weeks, as we said, to re-examine
Correct.
and look at it ourselves. And if the ankle looks like it's getting close to normal, then we know it's healing.
Great. So I think with winter coming and ice and we falling down, I think it's a great advice. Rise, I learned something, rest, ice, elevation, and compression. So keep that in mind and have a safe winter and be careful. Till next time, good night.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.